Hi everyone, and welcome back to the Prescribing in Surgery series. My name's Hermione, if you haven't met me before. Today we're going to be covering diabetes medications, but before we start, we have a guest with us, Daniel, who's going to give us a few words, and he's from the BMA, so I'll just hand you over to him for a little bit.
Thanks, Hermione. Just share my screen real quick. Okay, cool. There you go. All right. I'm sure everybody watching is in membership, so don't worry too much about this. But yeah, for anyone who's not currently, if you use that link that I put in the chat and also the QR code on the screen, if you join/rejoin the BMA, you'll get your first month membership free. This is a bit of an exclusive for Mind the Bleep. So yeah, you won't find this online anywhere else. So yeah, take advantage of it. If you're watching on repeat as well, it should still work, as long as it's not sort of 5 years in the future. So yeah, go for it. So yeah, I'll talk just a tiny bit before we start the session. So mainly giving a bit of an update on sort of what the lay of the land is at the moment in terms of strikes. Not too much to update you with on this current day. But yeah, just a reminder of what we do. We're obviously your union. In times past, we sort of get a bit of confusion between us and indemnity companies, so people like MDU, MPS. So it's just always worth reminding that we're sort of the non-clinical side of things. So anything sort of pay related, sort of relationships between colleagues, that kind of thing. It's us. Anything clinical is sort of MDU, MPS sort of side of things in indemnity. So 3 ways of looking at us as your union. We can help on an individual level, so things like your contract checking. I'll go on to look at that. So your individual sort of side of stuff. Local issues, so say you're a group of F2s, you're sort of facing a similar rota problem or something along those lines. We have people on the ground every trust, so we can help sort of trust level, so that's sort of the local side of things. And then obviously on a national level, there's what's going on with the strike. So yeah, three ways of looking at how we can help you. So yeah, just a bit of an update on what's going on at the moment. Obviously, today is the final day for the reballot for juniors. So the cut-off date for sending the envelopes back was Friday. So yeah, we should have an announcement on that result early next week, I'd imagine. We have them counted pretty quickly. So yeah, so tomorrow is the final day. It's looking like it's going to be a big turnout once again. Obviously, the last 2 reballots, the last reballot and the ballot before that were similar. I can't give you any news on any strike dates, of course, because we don't have the mandate as we speak. But obviously, next week when we get that mandate back, that means we can start planning more strikes if the government continues to not talk to us. So I imagine the next round of strikes would be at the end of April at the earliest, because we obviously have to give sort of a 3-week notice period. But that's just my take on it. It doesn't necessarily mean there will be any strikes at the end of April, by the way. It's just, you can sort of tell, everybody can sort of tell by the pattern of things, how things have been going. So the consultants are currently voting on an improved pay offer as well. There was that marginal no vote in January. I think it was 51% to 49%. So an improved offer's come in. So we imagine that will go through. They have until the 3rd of April to vote on that. And then, yeah, that'll be sort of the first, I don't want to say first domino, because it's different what's going on with the consultants to juniors. There's sort of needed tweaking, whereas we're looking to sort of overhaul pay and look for something a lot bigger in terms of percentages for juniors. But yeah, so keep an eye on the consultants pay offer. So again, we should have results pretty quickly after the 3rd of April on whether that's a yes, voting for that offer. So yeah, just quickly, just round off with just a few other things that we can help you with day to day. So that's some of the sort of frequently asked questions that we get on the screen. We solve pretty much every case that comes in within 3 months, so 85% of cases. 22,000 new doctor cases, junior doctor cases alone, we managed in 2023. So just think of us as the first point of call for any issues you might have. I know that HRs aren't always very forthcoming with answering queries and sorting things out to you, so you can get us involved. We do have people on the ground, every trust across the country. Contract checking, I mentioned this earlier. 25% of the contracts we checked last year were wrong in some way. Often it's around pay. So even if you've got your contract now and you're quite happy with it, you can just send it in to us anytime and we'll just check. And if there is anything and you are owed anything, then we can help get you any money back or get that contract changed retrospectively. Doesn't necessarily matter if you've signed the contract, because if you're given something wrong, then it shouldn't have been wrong in the first place. So you're not buying just because you've signed it. We negotiate the contracts for doctors in the UK, for better for worse. So we know what should be in them, and we didn't negotiate them just so they could be tweaked and you could be tricked. So always worth getting it checked. Rotor checking as well should be more standard. I'm sure you'd know by now if your rotor is possibly incorrect, but again, that's something that we can check and look over if you're unsure. You just want to speculatively get it checked. BMA Library. So BMA Library has moved entirely online now. We obviously used to have the library in central London, but everything's sort of turned into it's an e-library essentially now. But you can still go to BMA House if you're London based to use sort of the study space and whatnot. Clinical Key. So that's a point of care tool, breaks down conditions, gives you videos, links to all journals and books related to anything. Really useful to use. It's a standalone app. It's its own thing, but you log in through your BMA credentials. We run a series of webinars as well throughout the year, which you can watch. BMJ Learning, obviously free as part of your membership. And the BMJ, it's worth knowing that if you want to switch the BMJs off, you can do, but just by giving us a quick call and saying, I'd rather read them online, because you have access to them there. Specialty Explorer tool. This is essentially a psychometric test. If you guys are thinking about what specialty to go into, this is essentially a little test which will break down at the end all the specialties that would suit you according to the answer you've given, and it gives you lots of pie charts and graphs and reasoning why such specialties will suit you. We've got a good wellbeing service, confidential, of course, of the trust that you're working at. The unique thing about this wellbeing service is that you can speak to either a counsellor or a peer support doctor, so somebody who's perhaps been through similar situations to you and is a doctor themselves. Free to use for everybody, regardless of whether you're a member or not. That's it. I'll let you get on the session. I'll pass you back to Hermione. Thanks for listening. And that's it.
Thank you very much. Okay, great. So I can get going with this now. So just a few things to say about today. There are lots of guidelines on diabetes, and they do vary from trust to trust. So just to be aware, you should always check your local policies and follow your hospital guidelines. And the other thing to say is, I know sometimes it can feel a little bit one-sided with these webinars. So to address that, if you have any questions or any discussion points, please put that in the chat and we can do our best to explain any of the answers. This is the calendar for the next half of the series. So just to note here that there are 2 weeks off until the next webinar, which is on the 9th of April. And before we start, I thought we'd just go back to basics with insulin and other oral hypoglycemic medications. So type 1 diabetes occurs when your pancreas makes small amounts or no insulin. Just to recap on that, it's a hormone produced in your pancreas that helps you store your sugar from your food. And obviously, if you don't have any and you're not making any, then we need to replace it. So that's what we do with insulin, just providing exogenous insulin to prevent your hypoglycemia. This is some of the brands that are commonly used. So the short-acting ones, up here in Scotland, we use Nova Rapid, but there are plenty other ones. Intermediate acting ones, Humulin is the one that I'm most common with, but there's plenty of other ones. And long-acting ones here, Lantus, Levemir, and Tresiba. And again, just to recap on the modes of insulin as well. So we've got the pens that have pre-measured amounts of insulin, insulin pumps, which are automated, and syringes, which are sometimes used to draw up the specific amount. Okay, and then just to recap this graph, which I'm sure you will see plenty of times as well, just to remind you of the durations of various insulins. So rapid acting does what it says on the label. It acts very quickly, within 5 to 10 minutes. So we normally use this before meals. So it's the insulin that patients will need just before meals as a quick burst of insulin to deal with the carbs from the upcoming meal. And in hospital, this is the kind of insulin that we prescribe before meals, and it's dose dependent on their blood glucose and how many carbs they're eating. So, for example, you might be prescribing 2 units of NovaRapid before breakfast. Short acting is very similar to rapid acting, but it takes a little bit longer to work, which you can see here. Normally 30 minutes to an hour. And normally if you're taking a rapid or short acting insulin, you'll also be taking a background insulin. So that's either intermediate or long acting insulin. So if we start with intermediate acting, you can take this once or twice a day, usually in the morning and the evening. Long acting insulin is slower than that, so it takes 1 to 2 hours to work. And again, you normally take it once or twice a day. And a good thing to know about these background insulins is that they're commonly used in type 2 diabetics as well, who sometimes have enough insulin on their own, but they need a sort of top up. So they have this morning and evening regime. And there are such things as mixed insulins, which you probably heard of before. And they're a mix of the intermediate insulins alongside your shorter acting ones. So it can be taken before meals. Brand names include things like Humulog, but just so you're aware before we get started. One more slide before we get into the questions. This summarizes most of the type 2 diabetic medications that we see in hospital. So not only are there different rules for them with surgery, but they also have different side effects and contraindications. So it's just a chart to be aware of. Okay, so into the first case, we've got a 56-year-old lady who's admitted for an elective cholecystectomy following a diagnosis of gallstones. The surgery is planned for tomorrow afternoon, so she will be fasted for both breakfast and lunch. Past medical history includes biliary colic and Meniere's disease. She takes atorvastatin, insulin, and beta-histine, and that's her insulin regime. So the question is, on the day before the surgery, what insulin regime would the patient get? Okay, so we've got a few answers here. So the answer here was A. The key with this question is that it is the day before the surgery, so we can assume she's still eating and drinking normally. We continue the rapid acting as it's normal, and we give 80% of the long acting insulin, which is why it's 12 units. Okay, any questions about that? So just to recap on this is the BNF. It's got the page on diabetes, drugs and surgery, which is very useful. It's advising us here to give 80% of the normal background insulin. So that would be 0.8 times 15, which is what gives us our 12 for our 12 units of Lantus. Okay. Okay, so moving on, same case, the patient's been given 80% of her Lantus dose and her normal short-acting insulin the day before. We're now on the day of the surgery and her blood glucose is 5.6. She's due to go into surgery around 2:30 p.m. and so she is fasted for at least 12 hours before. So a few things about this before answering the question, and feel free to put this in the chat. What are we thinking about with this surgery? So we need to think about when the surgery is, so how many meals are being missed, and what her blood glucose have been like, and what her normal regime is. And just to recap you of her previous regime, it's NovaRapid 4 units 3 times a day, and Lantus 15 units once daily. So the question for this is, on the day of the surgery, what insulin regime would you prescribe? So I'll put that up in the poll now. Great. So the answer here is E. So again, we're giving 80% of the Lantus, so that makes it 12 units instead of 15. And we're stopping the short-acting insulin because she's going to be fasted for 12 hours, so she'll miss at least 2 meals. And we're going to start a variable rate insulin infusion. So this just shows where we've got this information from, again, the BNF. So the key things to consider here are the fasting time. Here it says that you'll need a variable rate insulin infusion if they're missing more than 1 meal or if their diabetes is poorly controlled. Below that, so still keeping the patient on 80% background insulin. And then on the right-hand side, we have some information about variable rate insulin infusions, which we're going to spend some time going through in a little bit. Does that all make sense? Any questions? Okay, so we're going to talk a little bit about variable rate insulin infusions because they're quite a hot topic in surgery. So it's really worth getting a solid understanding of them. If we start from the beginning with what they are, it's an IV insulin infusion of a variable rate according to regular capillary blood glucose measurements with the aim of controlling serum glucose levels within a specific range. So it's also important to remember that they must be accompanied by an infusion of fluid containing glucose, and that's to prevent hypoglycaemia. In a nutshell, if you start a variable rate insulin infusion, you've got to make sure you've got a bag of fluids with glucose alongside it. And that makes sense if you think that the patient's probably going to be fasted or not eating normally. You're going to need to give them some glucose or they'll have a hypo, okay? Indications for variable rate insulin infusions. So anyone with diabetes or high blood glucose sugars, anyone with diabetes or high blood sugars in hospital who can't take any fluids or food, anyone who's fasted for a prolonged period of time, so anyone going in for a prolonged surgery, if they're vomiting or nil by mouth, so this could be someone with an obstruction, for example, and anyone with severe illness where it's difficult to manage their sugars. So your classic patient is one who's septic or perhaps a hypoactive delirium. So I've made a quick table to cover the pros and cons. Pros, obviously, you're able to manage blood sugars which aids with your clinical outcome. Cons, they need hourly CBGs, and it can cause hypos or hyperglycemia, fluid overload, and electrolyte imbalances. However, if we try and manage the variable rate insulin infusions, you hopefully don't need to worry too much about those. And then this is just the BNF guideline, so it tells you how you're making up an insulin infusion. So you're going to put in the insulin with some sodium chloride. This would normally be a nurse doing this. And you need hourly BMs for the first 12 hours. And you can change the rate of insulin according to the BMs. We're aiming between 6 to 10 millimole per litre. Okay? So this shows a trust guideline for a variable rate insulin infusion. I've said it before and I'll say it again, always use your own guidelines. But this one is nice because it gives you some indications, which we've covered. So it's also used in ACS with poor glycemic control and after strokes. But here we're focusing on surgery. There are a few exclusions to know about on the right-hand side. So ICU, pregnancy, peds, and people with DKLHHS. And there's some guidance at the top here. Just reminds us to continue using our background insulin at 80%. Get diabetes involved if you have any concerns, and the contents of the infusion. So here they're using Act Rapid. So you dilute 50 units of that with 50 milliliters of 0.9% saline. So your concentration is 1 unit per mil. Again, some trusts use different insulins, but Act Rapid is quite common. And then on the bottom left, there is some guidance on fluids to give alongside. So this varies the most between trusts. Normally, it's a mix of sodium chloride with some dextrose, plus or minus some potassium, depending on the level. In Scotland, we normally give 0.9% saline with 5% dextrose, and then we add the KCl in alternating bags of fluids. So just double check what your guidelines say for that. And final note on TPN. So if a patient is on TPN, they don't need to have the same number of regular bags of fluids because they'd be receiving glucose and electrolytes in that TPN. And then just to say, we normally set the rate between 70 to 100 mils per hour for the fluid. So here they've said 80 mil per hour. So that's your fluids that are going to be running alongside your variable rate insulin infusion. Okay, and just to run over setting them up. So we've mentioned you can use different fast-acting insulins, and you make it up to a concentration of 1 unit per mil. Of note, they have to be changed every 24 hours, so they are quite intensive for the nurses. And the variable rate insulin infusion needs to be prescribed. There's usually a specific prescription chart for them as well. And important to touch on, there are 3 different rates that you can normally have. The standard one is the one in the middle. You can have a reduced rate for those who are insulin sensitive or have a reduced clearance. So those with renal or heart failure or frail elderly patients. And then there's a higher rate for those who are insulin resistant. So on the prescription chart, depending on your capillary blood glucose results, it may recommend that you move someone up or down a scale. So for our protocol, if the blood glucose is more than 11 on 2 consecutive readings, then you'd want to be switched to a higher regime. The specifics of these range from trust to trust. So, for example, another trust recommends increasing the scale if the glucose is more than 12 for 3 consecutive readings. So just get familiar with your own guideline, as always. And again, there's lots of monitoring required every hour for the first 12 hours at least. And we like to use a dedicated cannula for the variable rate insulin infusion. So they're going to always need at least 2 cannulas in, one for that variable rate insulin infusion and one for the fluids. And it's important to know that you'll need to be ordering daily bloods because they need using these done to just check their electrolytes aren't deranged. Sorry. And finally, I know we've just touched on it, but just to mention again that you don't need to be giving the exact same number of fluids with glucose if you had any kind of enteral or parenteral feeding, so anything via an NG, NJ, a PEG. And it's really important to be extra vigilant if patients are coming off enteral or parenteral feeding, because if it's stopped, it can then lead to a hypo because they're no longer receiving that glucose. So they would then need to have a mixed bag started. Okay. This just shows you what some of the protocols look like and what they recommend for dosing. So below 4, we want to be treating hypoglycaemia. Apologies. In the middle there, we can see the dosing varies slightly depending on the scale and what your CBGs are. And this just shows us what the monitoring sheets look like. Obviously, it won't be all the same, but something similar to this. So it has where your CBGs are recorded, which scale and how much insulin they're being given. And then you'd also have to have the prescription alongside that. Before we move on, are there any questions about variable rate insulin infusions? No? Okay, great. We'll move on then. Okay, so this is part C. So our lady has been converted onto a variable rate insulin infusion and she undergoes surgery. So her surgery is successful, and post-operatively, she has some vomiting and nausea. She's prescribed some morphine sulfate and some ondansetron. She remains on the variable rate insulin infusion, and her BMs and ketones are normal. So our next question is, when should she be converted back to regular short-acting insulin from the variable rate insulin infusion? Okay, great. So lots of people got the answer here. The answer is C. If anyone has any questions about this, please let us know. But essentially, we need to ensure that she's eating and drinking properly before she can come off it. And this is a really good flow chart that just shows when we should be switching people from a variable rate insulin infusion back to the normal regime. So the first question is if they're eating and drinking without nausea and vomiting. And the concern here is that if they're vomiting, obviously that's an issue for glucose control. If they're nauseated, we've got to wonder if they're actually going to be eating properly. So if you're eating and drinking well with no nausea or vomiting, then you can be switched back. For her, she was on insulin, so the guidance here suggests we resume her normal long-acting, so she can go back to her 15 units. And we should continue the variable rate insulin infusion until an hour after she's received her insulin to make sure she's covered. And we can resume her short-acting with the next meal. And again, from trust to trust, I'm sure they'll have something similar to this that you can look up if you ever forget. And this is just to reassure you all that this information can be found on the BNF if you're not sure what's going on. So it gives you your conversions back from variable rate insulin infusions and when to start them. Okay, moving on to case 2. So here we've got a 48-year-old male who's admitted with necrotizing fasciitis of the leg and requires urgent debridement on a general anesthetic. These are his OBS. So he's got a temperature, he's tachycardic, and he's got a bit of hypertension there. Past medical history include type 2 diabetes, hypertension, and angina. And drugs history, he takes a gliclazide, 80 milligrams, amlodipine, 10 milligrams, GTN as needed, aspirin, 75 milligrams, and atorvastatin. So the question here is, what would you do with the gliclazide? So it sounds like an emergency surgery, doesn't it? So I'll put this poll up for you. Okay, so we've got a bit of a spread here for answers. So the correct answer is D. So we're going to want to withhold the gliclazide from the morning of the surgery. So unfortunately, his medication chart is not reviewed, and he receives his gliclazide whilst an inpatient. 2 days post-operatively, he becomes nauseated and fatigued. He's got some blurred vision and a new headache. So looking at his OBS here, he's pale, shaky, and weak. He's got a new irregular heart rate and is tachycardic. He's mildly hypertensive and has new confusion. Chest is clear and no temperature. What is the likely cause of his presentation? Okay, so it looks like quite a lot of you got this one right. The answer here is C. So these are classic symptoms of hypoglycaemia. So he hasn't got a temperature. So the first line of call wouldn't be sepsis. And he's got his confusion, he's got irregular heart rate, he's pale, shaky, and weak, and he's been given his gliclazide when he shouldn't have been. So again, we've got a slide here showing the BNF. So this is linking our sulfonylureas, so our gliclazide in this scenario, associated with hypos if they're not admitted on the day of surgery. So these are some of the symptoms of hypos to be aware of. In our patient's case, it's very severe because he's got this new arrhythmia. So he would need urgent IV glucose. It's just to sort of show you how much of an effect these drugs can have if we don't give them on the right day. Okay, so case 3, we've got a 37-year-old female. She's admitted for an elective minor operation in the ENT department. She's having a tonsillectomy and should be able to be discharged home on the same day. She has asthma and type 2 diabetes, and her drugs include salbutamol and sitagliptin. So the question here is, what changes would you want to make to her diabetes medications during the surgical period? So the poll is now. Okay, so the answer here is D, so we'd want to give it as normal. Apologies, sorry, I've got a horrible cough. So anyone in the chat, which oral hypoglycemic agent is this? Does anyone know what type of drug a sitagliptin is? Yeah, exactly. So it's DPP4 inhibitor. So this is one of the drugs that we can continue as normal. So as the fasting time is short, this is a minor procedure. Some agents can be continued. So here, this is BNF, shows our DPP4 inhibitors and our GLP-1 receptor agonists can be taken as normal. Okay, so moving on to case 4, got a 42-year-old female who's presenting with appendicitis. So she's admitted for surgery and for the following afternoon, and she fasts from midnight. She's type 2 diabetes, obesity, hypertension, and iron deficiency anemia. She takes ferrous fumarate, ramipril, and metformin twice a day. Looking at her blood, so she's mildly anemic. She's got a raised white cell count and CRP, so it looks like she's got an infection. And urea is normal, creatinine is raised, EGFR is down. So how would you manage her glycemic control? Okay, so that poll is now in the chat as well. Okay, great. So lots of you got this one right. A is the answer here. So we want to stop the metformin before the fast, and we want to start a variable rate insulin infusion. So the important factor here to have recognized is her low renal function. So her creatinine is very high, 191, and her eGFR is only 28. So I think this question warrants some explaining. We've got the management of metformin here, and it varies based on a few factors. So we've got renal function, we've got the length of the fast, and the regime of metformin. So once daily versus twice daily or 3 times a day. So guidelines from the BNF here on the right-hand side. So if you've got good renal function and a short fast, you can actually continue the metformin. If you've got a long fast or a reduced renal function, then you need to withhold the metformin. So this is the case for our patient, and only if they're on a BD regime, which is withheld, then you need to start a variable rate insulin infusion. And our concern for the lady here is lactic acidosis due to the accumulation because of her renal impairment. Okay. Any questions about that? Okay. So question 5 here, we've got an 81-year-old gentleman who's had a fall. He's admitted with a neck of femur fracture. He's due to undergo surgery tomorrow. All of his medications are continued, and he has started on morphine sulfate, paracetamol, and codeine. He's got congestive heart failure. He's got type 2 diabetes, COPD, osteoarthritis, and depression. Here is a list of his meds, including furosemide, dapagliflozin, Foster inhaler, salbutamol, cholecalciferol, sertraline, and alendronic acid. And our question is, what medical issue are we concerned about post-operatively, given all these medications have been continued during the surgical period? Okay, so the answer here is B. It is euglycemic ketoacidosis. So the SGLT2 inhibitors are the main culprits for euglycemic ketoacidosis during surgery. So they should always be omitted and only restarted when a patient is stable and eating and drinking as normal. And this is from the BNF, just highlighting that issue. Just to run through euglycemic ketoacidosis, so symptoms are similar to DKA, so you can get nausea and vomiting, abdominal pain, but sometimes they can have no symptoms as well. Triad of signs that we're looking for, so normoglycemic, they have metabolic acidosis, so they're going to have a low pH, and they're going to have reduced serum bicarb, and they're going to have raised ketones. And we manage it similarly to DKA, so you've got to follow your local trust protocol as always, but in essence, we're stopping the offending drug, so we want to stop the SGLT2 inhibitor. We continue the background insulin, and we give them fluids and insulin. And we want to monitor their BMs and their electrolytes and replace as needed. Okay. So the final case, I think we have here, oh, maybe not. Next case even, is a 32-year-old female who's been in hospital for an appendectomy. So she's type 1 diabetes, which is usually controlled solely by insulin before meals, so that rapid acting. Her insulin is restarted post-operatively when she is eating and drinking. Post-operatively, she is reviewed and is found to be hyperglycemic. So on examination, she's maintaining her own airway. She's got equal air entry. She's warm, well perfused. Her cap refill time is normal. Heart sounds pure and regular pulse. GCS is 15 out of 15, and her capillary blood glucose is found to be 18.5. Abdomen is soft non-tender. Calves are soft non-tender. So in this case, we've got a patient who's hyperglycemic, maybe because her insulin has been withheld. So how are we going to manage her hyperglycemia? Okay, so I think most people have answered, and the answer here would be C. So we want to give 4 units of NovaRapid. So this just explains my thinking in this scenario. So again, correctional doses can be varied from trust to trust and depends on which agent you're using. But with this guideline, as her blood glucose is more than 18.1, she's going to need 4 units. So as a general rule, 1 unit of rapid acting should aim to drop the blood glucose by about 2 to 3. So that would bring her BM down to about 10. So this flowchart also just explains how to manage an unwell patient with hyperglycemia. So we always want to check the ketones and rule out DKA and HHS. And if the patient is well, then you can give correctional doses. You can always get diabetic help if you want to change their sort of background or basal insulin. Just a summary of what we've covered today. Always use your own trust guidelines. And if you are struggling in hospital, the diabetes teams are always on a bleep, so they can come and review your patients and help change any of the medications as well. And these are my references as well. And looks like the feedback form's just been sent into the group chat. Thank you. So thank you for filling them in. As always, really appreciate your feedback. And we look forward to doing some more sessions with you in the coming weeks. Thank you very much for